to everybody. Happy Foundation Day to everybody. And I think I know most of you and most of you know me. So this is according to a request from the residents at our institution to give just a comprehensive talk about acute kidney injury. Very important topic, very common. We all encounter this every day in the hospital. And so what I'm going, my screen is clear, Asma, you see it? You see my screen?
Yes, doctor, it's clear.
Excellent. So my objectives here very quickly, I would like to finish this talk in about 35 minutes. I got 50 slides and I'm going to go try to pace myself to finish it in 30 minutes. And then I will leave about 10 minutes for any questions and discussions. But basically what I want to talk about, the question was basically about the approach to acute kidney injury. I'm going to talk about the definitions, the nomenclatures, the changing in the names, why we don't use renal failure anymore, or any organ failure for that matter, even for lung or liver or other organ. Now we talk about injury, we don't talk about failure. Failure is a bad word. And failure really, in kidney, in nephrology, failure means end-stage renal disease. That is a GFR of less than 10%, and dialysis and or transplantation. So we're not talking about failure. And failure sounds bad for doctors and to patients. When you tell patients you have kidney failure, that's a bad word. It actually is not really failure, it's injury. I'm going to talk about the staging system for AKI. I'm going to talk about some caveats or reservations in patients who have high creatinine, high BUN, but they don't have any kidney problem. That's important to differentiate. I'm going to talk about the causes, assessment of the patient with AKI, differentiation of acute versus chronic complications, and treatments of the major life-threatening complications of acute kidney injury. So let's start with the definition here. The definition, the definition has not changed. I will talk about this in subsequent slides, but basically it is a sudden loss of kidney function over several hours to days, resulting in severe derangement in extracellular fluid, acid-base balance, and electrolyte regulation. So these words are still the same. They has not changed, even though the terminology has changed now. So the new definition using, that first definition is still valid, but this is the new definition of acute kidney injury after the nomenclature was changed. It's an abrupt, within 48 hours, reduction in kidney function, currently defined as an absolute increase in the serum creatinine of more than 25 macromole or millimole per liter, or a percentage increase of 50% or a reduction 50% from the baseline creatinine, or a reduction in the urine output, documented oliguria, of less than 0.5 ml per kg per hour for more than six hours. These durations are important to define acute kidney injury. So this is why did they change the name? Why not? What's wrong with acute renal failure or acute kidney failure? Because number one, this was very confusing for people doing research in different parts of the world. You have people doing research in China, in Germany, in Sweden, in the United Kingdom, in Saudi Arabia, in the US. So there was a complete lack of standardized criteria for diagnosing and classifying what used to be called acute renal failure. And this has hindered or make it difficult for the development of good clinical therapeutic trials. So when you look at papers or studies in the New England Journal of Medicine from anywhere in the world, you want to make sure that creatinine, in all papers, in all studies, they used to use the reciprocal of the creatinine, 1 over the creatinine. They're just trying their best to standardize the definitions or the numbers, because so people in different parts of the world would be talking about the same thing. So this has hindered the development of good clinical therapeutic trials and comparing those trials. Acute Dialysis Quality Initiative Group proposed a consensus recommendation of what we call the RIFLE. That's the risk of the kidney injury, the injury itself, the failure, the loss of function, and the ESRD. This is called the rifle for the definition and staging of acute renal failure or acute kidney injury in 2002. That's 20 years ago. And then the acute kidney injury, this is the new term proposed by the AKIN. The AKIN is the Acute Kidney Injury Network. This is a group of experts from different parts of the world who are nephrologists mostly. They have a consensus in 2005 after a 3-day conference in Amsterdam in September of 2005, and they came up with this criteria. So we have the rifle and we have the AKIN criteria, different types of criteria, but they can be combined together. As you can see in your the left side of the screen there, there's the rifle stages, different stages, and then there is the AKIN stages. The rifle stages are, as I said, risk, injury, failure, loss, and ESRD. And the first letter of all these words say, means rifle, not what rifle is. And AKIN has 3 stages, stage 1, stage 2, and stage 3. So they use the same criteria as before, serum creatinine criteria and urine output criteria. So in risk group or a stage 1 AKIN, and the risk group of the rifle, it's an increase of serum creatinine of 1.5 to 2-fold from the baseline, or increase in serum creatinine, absolute increase of 0.3 milligram per deciliter, which in our labs and in our units is 25 millimoles per liter. Urine output dropping less than half an ml per kg per hour for 6 hours. So these are the criteria. Then the injury, together with the stage 2, the injury in the rifle with the stage 2 in the AKIN is an increase of serum creatinine of 2 to 3-fold from baseline. So these are stages of severity, both on rifle and on the AKIN. And also drop in the urine output for 0.5 ml a minute, but here it's for 12 hours. And then stage 3 in the AKIN, which goes together with the failure part, failure stage of the rifle, is an increase in serum creatinine more than 3-fold from baseline, or serum creatinine more than 4 milligram per deciliter. I mean, in our units, you multiply that by 88, so that's close to 350 or 400 millimole per liter. It's pretty severe. And then here also the urine output dropping further for 24 hours, or complete anuria. So that's here, that's failure. That's what I was alluding to at the beginning, differentiating between injury and failure. And then loss is loss. That's it. Kidney function is lost. Persistent renal failure for more than 4 weeks. ESRD, of course, end-stage renal disease. By the way, speaking about names and nomenclature, this ESRD now in most recent paper in 2020 and 2019, they don't use the word renal. That word renal is going out now. We're going to be talking about SCED, end-stage kidney disease. So that's coming. That's not still in the practice, but the ESRD word will change to ESKD. That's coming in the near future, inshallah, maybe this year. So the validation of these criteria I just talked about, they've been proven in big studies here. This is a huge study, 20,000 patients from Australia, just to validate these criteria. And this is another very large study also, 5,000 patients in the ICU. This is an American academic medical center studies. So they have been validated. Now, we have to be careful. You can have a very high level of BUN, up to 100 or more, and a very high level of creatinine in the absence of kidney injury. Kidneys will be perfectly normal. I remember seeing patients when I was a fellow who are big, very muscular, big, really huge athletes. They play American football. And after a big practice or lifting weight or very strenuous exercise, they come in with a creatinine of 2,000 and a BUN of like 200, but their kidney function is normal. We don't dialyze those patients. That's why we don't do dialysis based on numbers. So any excessive physical exercise can increase your BUN. Increase protein intake, amino acid infusion in your ICU patient, GI bleeding, steroid therapy and hypercatabolic state like sepsis or cytotoxicosis, all these can raise your BUN, just increased breakdown of muscles and increased creatinine, increased BUN, urea level. Increased creatinine can happen in severe rhabdo also, out of proportion of the degree of kidney injury. Reduced excretion of creatinine, we know this happened with Bactrim, trimethoprim, sulfamethoxazole, and several other drugs, but the most well-known one is Bactrim and cimetidine, Tagamet, if you're still using that. So these can reduce the excretion of the creatinine in the tubules and not give you a rise in the kidney without kidney injury, no kidney injury. Also in the labs, there are certain medications we commonly use in our patients like antibiotics, cefoxitin, flucytosine, even vitamin C, ascorbic acid. They interfere with the assay and they give you an erroneously high creatinine. That's just the assay itself in the lab. And then creatinine chromogene will be recognized as creatinine. Chromogene is pigment protein in the lab. So you give you a false. We just have to be aware of these reservations or caveats, as they call them. These are the causes. Now, as you can see, ATN, acute tubular necrosis, is still the most common cause. It's almost 45, 50% of the causes. And then the other two big ones are pre-renal, azotemia, and of course, the patient who has pre-existing CKD and they come in with anything like community-acquired pneumonia or COVID or anything, they can have acute on chronic kidney injury or kidney failure. And then you have the obstruction, and then there are, excuse me, and then there are other other causes like rapidly progressive GN. When we see that and we find it, we get very excited because that's just a change from what we normally see. I like acute interstitial nephritis. I like to diagnose it because you can cure it completely with steroids if you can diagnose that acute interstitial nephritis. And then, of course, the minor, the less common things like renal artery stenosis, renal vein thrombosis. These are the main causes of acute kidney injury. Here also you can look at the pre-renal azotemia, intrinsic causes, post-renal causes. The intrinsic causes further divided to ATN. ATN is mostly 50% ischemia, and the other 35-40% toxin exposure or medications or contrast. And then you have the interstitial nephritis and the GNs there. How do we assess patients with acute kidney injury? We have to get a good history of from the charts. We have excellent charting system here. You can go back in the history, you see where what was the baseline creatinine in the past. That's a prior BUN creatinine, very important. Nephrotoxin exposure. Don't forget over-the-counter medication, especially NSAIDs. Documented episodes of hypotension. Look in the chart since the patient hit the emergency room. Did they have any documented episodes of hypertension? Are there any predisposing condition, diabetes, hypertension, heart failure? You have to also briefly ask about the family history of any renal disease and any personal history of kidney stones or urinary outlet obstruction, any prosthetic symptoms, for example. Physical examination, assess the volume status, very important. Look for tachycardia, orthostasis. These are very solid, objective, convincing findings. You can easily ask the nurse, I want the blood pressure lying and I want it standing, or if the patient can't stand, just get the legs down the side of the bed and check the blood pressure again. We want to see 20 millimeter mercury drop in the systolic blood pressure. And look at the serial weight. That's what we do in our patients in the floor. We weigh them daily, and we want to make sure if they come, below their prior weight, or we especially in our transplant patient, we want to see their weight pre-transplant, post-transplant. So weight is very important. Again, very objective. Assess for congestive heart failure, liver cirrhosis, skin changes indicating GNs like the purpura and the livido reticularis. Any limp ischemia. Examine physically, put your hands above on the bladder if you feel any distended bladder, or in the costovertebral angle, looking for any evidence of tenderness there or prostatic hypertrophy. Okay, so acute versus chronic. I know this is something that people talk about a lot. How do we know this is acute or chronic? Very simple. Uh, Kidney size, very important still. A kidney that's 8 centimeter or less, that's a small kidney. Okay, so if the kidney is normal in size, that most likely the patient has acute kidney injury. Um, if there is broadcast in the urine analysis, that indicate chronicity. I will show you pictures of cast, different kind of cast at the end of this talk. History of kidney disease, the patient has pre-existing history of kidney disease. That points more towards chronic CKD. The presence of anemia, metabolic acidosis, hyperkalemia, and hyperphosphatemia that you can see on both of them, acute or chronic. So it doesn't help you, these findings. Some people say anemia doesn't really occur in AKI, but the patient can sometimes have anemia, depending on the half-life of the erythropoietin and the ability of the kidney to produce erythropoietin, and hypoxemia, intrarenal hypoxemia. Reversibility, of course, AKI, we usually expect complete resolution, complete reversibility. CKD, you can also, as I said earlier about acute or chronic, the acute component can improve with proper management, and then you get the patient back to their baseline, kidney function, back to where they were in terms of their CKD. The pre-renal causes, if you're dealing with a community patient coming to the ER or coming to your clinic from the community, this is pre-renal erythema constitute the vast majority of causes there, 60% of the cases. This is usually related to excessive non-replaced fluid deficits due to GI losses, vomiting, diarrhea, renal losses, excessive diuresis, over diuresis, or cutaneous losses in the summer. And then if you're dealing with a pre-renal azotemia or pre-renal AKI in a hospital patient who came in with normal creatinine, and then they develop AKI during their stay, very common scenario. This is primarily due to the decreased effective renal perfusion, such as in patients coming with CHF, cirrhosis, sepsis, you name it. This is a really, really important slide. And I want to explain here the renal autoregulation. So focus with me. I have 3 panels here. I have a top panel here. I called it normal condition. And then that's B1 here at the top. And then we have B2, and I'll explain each one in details. This is really important. And then we have B3. When you see the plus sign here, that's vasoconstriction, and then the negative sign means vasodilatation. So let's look at the top panel. That's perfectly normal individual with normal kidneys. And so what you see here is the afferent arteriole going into the glomerulus, and then an efferent arteriole coming out of the glomerulus. And then you have a tubule there where if the glomerulus is filtering, you have good functioning glomerulus, normal intraglomerular pressure, good perfusion pressure to the glomerulus. So the kidney will filter, the glomerulus will filter what we call the glomerular filtration here down the tubules, and then it goes down. This is God's creation. The patient is not on any medication, is not on anything. I'm just showing you the physiology. This is the basic physiology. What maintains this renal autoregulation? As you can see, I put autoregulation here to regulate and control the afferent arteriole and the efferent arteriole. What control this system here is 2 mechanisms. These are physiologic mechanisms. We have the myogenic reflex, and that is if the blood pressure rises, systemic blood pressure rises, that causes a stretching of the smooth muscles in the arterioles there. And they just adjust to the rise in the blood pressure. And the goal here is to maintain intraglomerular pressure so the glomerulus will filter. And then you have the tubuloglomerular feedback mechanism. This is controlled by the uh, uh, juxtaglomerular apparatus, or what they call the macula densa. And basically, it has sensors. These cells have sensors in it. These are cells in the wall of the tubules adjacent to the afferent arteriole and the glomerulus. So they actually sense the sodium concentration in the tubules, and they feed back to the glomerulus. So they send messages. So this is a very tight, well-controlled God creation system that is not at fault. It's perfectly functional here. Now, if the perfusion pressure is reduced, okay, it's still within, but it's still within the regulatory range of this system here I'm talking about. The system is still functional. It can adjust. So we have, for example, in patient with heart failure, renal artery stenosis, diuretic therapy, nephrotic syndrome, you name it, the prostaglandin E2 enzymes or hormones here, they are controlling the vasodilatation of this afferent arteriole. If you block that prostaglandin system by, for example, non-steroidal anti-inflammatory drug, NSAID, these are prostaglandin synthetase inhibitors. They inhibit the prostaglandin. So that will cause, this is how NSAID cause renal acute kidney injury. Okay. Simultaneously also here, to maintain the intraglomerular pressure, angiotensin II control the efferent arteriole. But if you're giving this patient ACE inhibitor, ARB, or direct renin inhibitor, you're blocking the angiotensin, and you're taking this out of action here, the effect of angiotensin. And what happens? You get preferential efferent arteriolar vasodilatation. What does that do to the glomerulus? It lowers the intraglomerular pressure. What happens if you lower the intraglomerular pressure? Look down here, the glomerular filtration drops. So this is how this system works. So, and I just showed you how NSAID, COX inhibitors, and ACE, and ARB, and DRI, how they cause a acute kidney injury. But this slide is very helpful in demonstrating the hemodynamic effect on the glomerulus. The causes of pre-renal azotemia is decreased effective circulating volume below the autoregulatory range I just talked about. Hypovolemia, hemorrhage, fluid loss from GI, renal, skin, cardiac failure, also myocardial dysfunction. We know the relation, the cross-organ talk. The kidney talks to the heart talks to the kidneys. You have severe myocardial dysfunction, ejection fraction 20%, that's going to hurt the kidney seriously. And of course that include tamponade, pulmonary hypertension, valvular disease. And if you have a situation of systemic vasodilatation, like as in sepsis or cirrhosis or anaphylaxis, also that will result in a pre-renal state. Interference with the autoregulation, the GFR autoregulation, afferent arterial vasoconstriction. I think I described all these things just now. Just going to go to the next slide. The post-renal account for about 10%, 5 to 15% of community-acquired acute kidney injury. If you have history of prostatism, urinary stones, medications causing crystalluria, such as sulfonamides, acyclovir, methotrexate, protease inhibitors in patients with HIV/AIDS. You have to check for patent urinary catheters. If the patient already had the catheters, a lot of time they get kinked and they get misplaced. Get a renal ultrasound, very important. We're actually trying to get our own ultrasounds as part of a physical examination. We can diagnose that pretty easily. This is a normal kidney at the top. You see it, normal size, good size kidney. And you can see the difference between an obstructed kidney and hydronephrotic kidney here. Very dilated renal pelvis. This is a renal pelvis. And if you're lucky, you see the ureter actually in a second view. If you move your scanner a little bit, you can actually see the ureter, and you can even diagnose hydroureter. But here I can only say there is hydronephrosis, very dilated renal pelvis. Again, I love this. If you can, I love acute interstitial nephritis. It's completely reversible. Just a short course of steroids, and the patient would have normal renal function, no matter how severe it is. So this is something you don't want to miss. get it diagnosed. If it was very rewarding to you and to the patient. Uh, it's usually mostly secondary to drugs or systemic infection, penicillins, NSAIDs, sulfur drugs, even diuretics. These are the common offenders. Manifested as fever, rashes, and hemophilia are common. Uh, Urine analysis shows a lot of WBCs. Okay, so if you're lucky, you can see eosinophils, but I have never seen eosinophils in the urine personally. If you do a biopsy, you could see them in the kidney tissue. Uh, Not a lot of proteinuria, except in the cases of AIN, acute interstitial nephritis, due to NSAID, you can see proteinuria. Uh, I think here, because NSAID also cause what they call podocytopathy. They affect the podocytes, just like you see with minimal change disease. It's not due to the AIN itself. It's due to the effect of the NSAID on the podocytes, and that causes proteinuria. The right stain or Hensel stain for eosinophils, if you're lucky. I'm just putting this for, nobody's ordering these anymore, but I'm putting it here for completion. NSAID-induced acute kidney injury. I talked about prostaglandin inhibition. I mentioned this just a few minutes ago. Predisposing factor here for NSAID-induced acute kidney injury are CHF, cirrhosis, nephrotic syndrome, CKD, pre-existing CKD, atherosclerotic renal arterial disease, and hypovolemia. It's implicated in allergic interstitial nephritis with minimal change nephropathy, as I just said. GN, of course, GN, we love those GNs, and we love to make the diagnosis and do the biopsy. Again, because they are reversible, they are treatable in the acute stages. Examine the urine. I will show you the typical classic urine finding of acute glomerulonephritis. Often accompanying systemic disorder, secondary GNs like lupus, hepatitis, especially the C and the B, pulmonary renal syndrome, the good pasture, the Wegener's. Nobody says Wegener's anymore. So don't say that where it's Wegener. These are clinically very important because they're rapidly progressive and the patient can lose the kidney function very quickly. Complement may be normal or low, but low complement strongly suggests certain types of glomerulonephritis, what we call the immune complex mediated GNs. ATN, as I said in the pie chart, I showed you that this is almost 45–50% of the causes, most common cause of hospital-acquired ATN, AKI. ATN is caused by ischemia or nephrotoxins. So the same factors that cause prerenal acute kidney injury can lead to ischemic ATN if left uncorrected too long. Okay, so you could have a patient with prerenal azotemia, simple, straightforward. If you drag your feet and you hand it over to the person next to you or call after you, and then that person leave it to somebody coming on after the weekend, that prerenal azotemia can get converted to ATN. Okay, this slide is really nice. If you follow me, look at 11 o'clock here. This is the normal cross-section of the tubules. These are all cross-sections of the same cross-section of the tubules. This is normal. This is what it looks like in a perfect situation. You see the tubular cells, you see the brush borders here and the epithelium of the tubules. You see the integrin sitting here, maintaining the integrity of the tubular cells. You see the nuclei there, the sodium, potassium, ATPase system. So this is what a normal cross-section of a tubules look like, 11 o'clock here. When you go to 2 o'clock here, the first thing that happens is loss of polarity. What do I mean by that? You see the integrins were here sitting on the outside of the tubules. Now they moved in, so the polarity was lost. The brush borders, look here. The brush borders were all gone. Brush borders are extremely important, you know, moving things down the tubules, and they're done. Here, the tubules is dead. This is a dead cell, dead tubules here. This is necrosis. This is where the name came from. acute tubular necrosis, ATN. So the tubular cells are dead and fragmented, and this is called apoptosis. Necrosis, here it is. These are necrotic. You see the color is even different. And then sloughing, they get sloughed, these dead cells and all this junk, it moved down in the lumen of the tubule. So sloughing of the viable dead or the dead cells are sloughed, and they move down the lumen of the tubules and they obstruct it. So you get tubular obstruction by the dead tubular cells. And then of course, ATN always recover, even if it takes 3 months. It's always a good thing. It's always, I have never seen ATN causing ESRD or ESKD, please. And in the United States, whenever we put patients on dialysis, we have a list of codes, just like our codes in our system here, Rabbit. You know, you have a diagnostic codes. ATN is not one of the accepted codes to label a patient who entered dialysis or having a transplant. For example, I cannot transplant anybody whose renal disease diagnosis is ATN. You can't do that. It's not acceptable. That's because it's reversible. And here we see the reversibility, and the tubular cells get spread out, they redifferentiate, they proliferate, they recover, and boom, we have normal tubules. You know, ATN is reversible. ATN is not a cause of ESKD or ESRD. Okay, it always recover, even if it takes, you know, no matter 2 months, 3 months, it recovers. Contrast-induced nephropathy, you see a lot of that. We have a lot of intervention. We have a big cardiac center. We have very active interventional radiology department. This is it. Basically, the pathology here is just vasoconstriction and intratubular precipitation of the contrast and the generation of free oxygen radicals that toxic to the kidney, to the tubules. I don't see the time, yeah, Asma. Are we okay?
Yes, doctor, we are okay.
Okay, good. So contrast-induced nephropathy, you know, there is no role for bicarbonate, guys. Okay, don't give bicarbonate. Even Mucomist is not in the most recent criteria. We do it, we give it, but it's not really helpful. It treats us. There's a lot of conflicting data about these things. Hemodialysis or hemofiltration, if it's needed, we do it, but it hasn't been proven. Basically, the treatment is normal saline. These are the current recommendation from Kidney International. Optimize volume status, identify patient risk, try to convince the radiologist to use low osmolality contrast agents. In our practice now, we identify patient at risk, we give normal saline, 1 to 1.5 ml per kg per hour, starting 3 to 12 hours before procedures and continue for 6 to 24 hours afterward. That's it. So that's the mostly recent recommendation as far as contrast-induced nephropathy prophylaxis is concerned. Aminoglycoside, we don't use a lot of these anymore, I think. In the days when we were using gentamicin and topramycin a lot, it was really common. Highly cationic, this antibiotic interact directly with lipid in the cells and organelle membranes, interfering with phospholipases. Affect both proximal and distal tubules, resulting in non-oliguric ATN. Okay.
Yeah. Can I ask one question?
Sure.
Regarding contrast-induced acute kidney injury.
Yes.
Now we have this practice in the hospital that we counsel the patient that contrast can lead to a permanent or end-stage renal disease.
Yes.
And the patients might need dialysis for life. But when I read recently about the contrast-induced acute kidney injury, it never let patients go into end-stage kidney disease.
Yes.
Kidney
absolutely. So, you're absolutely.
I just need the clarification regarding
absolutely. You're absolutely right. It causes ATN, and I just said ATN almost always recover. ATN is not one of the causes of acute kidney injury. There is a tubular injury from the iodinated contrast, but it's not. Now, I just want to say something here. I didn't put a slide, but there is actually data when you tell the patient, hey, listen, you're going to need a CT angiogram or contrast study. Depending on their prior serum creatinine, you can classify the risk. I personally, when I talk to them, I say, look, your creatinine, for example, is 2 milligram per deciliter or 170 ml per minute. Your risk of contrast-induced nephropathy is near zero. It's less than 5%. If your creatinine going into the contrast, getting the contrast is like 3 to 4, like 300, 400, it goes up to from 5 to 15%. If your kidney function, or I'm talking about the need for dialysis post-contrast exposure. I'm not talking about end state, precipitating end state. It's reversible. It is reversible. You may need dialysis. The patient may need dialysis post-contrast, but it's reversible. It doesn't cause, and in itself, it doesn't cause end-stage renal failure. Okay, myoglobinuric acute kidney injury. Again, I mentioned that briefly before. In the case that I saw with creatinine of 2,000. Urine analysis is extremely important. Just a dipstick. I prefer to do that myself, but here we need. We don't have our own little labs. I think Dr. Sultan is going to help us set up a small lab to do that ourselves. We like to examine the urine ourselves to look for any changes. The indices, you look for specific gravity, the urine sodium. So for example, contrast-induced nephropathy and hepatorenal syndrome, the urine sodium will be extremely low, very low. ATN and others. So the urine sodium can really help you in terms of help you with the diagnosis. The FENA is still important. I asked for it. This is how you calculate it. The fractional excretion of sodium, very important. And these are the conditions that cause low FENA, pre-renal state, acute GN, vasculitis, early obstruction, FENA more than 1%, ATN, as I said, pre-renal state in patient with CKD, pre-existing CKD. Okay, so this is the urine chemistry and differential, helping in the differential diagnosis of pre-renal versus ischemic ATN. Not going to go in detail. This is red cell cast. If you see this, I mean, it's pretty much diagnostic of a GN or a vasculitis. This is if you can document red cell cast, you're very lucky. It's just like a non-invasive renal biopsy. To me, this is non-invasive renal biopsy. Then this is your granular cast. You typically see with ATN, very muddy, reddish cast, no cells, but just granular cast. And this is dysmorphic RBCs, very diagnostic. You see those acanthocytes, the RBCs are like bitten. You can, if you focus and you look at this, so you can see them bitten or like, basically with the GN, severe GN, glomerulonephritis, inflammation in the glomerulus, the red blood cells are squeezing themselves through the damaged glomerular membrane, the microstructures, and in that process, they get eaten or bitten by the severity of the inflammation. So you see these dysmorphic RBCs, very diagnostic. These are just different kind of crystals. Cardiovascular complication with AKN and salt and water retention, volume overload, pulmonary edema, hypertension, pericarditis. This all can happen in patients with severe AKI. GI manifestation also, anorexia, nausea, vomiting, GI bleeding also in 10 to 30% of patients with AKI. Infections, these patients are prone to infection for sure. They have impaired immunity as well. Defective leukocyte function, disruption of the normal anatomic barriers. It's a really a problem. The prognosis, ATN usually lasts 7 to 21 days. I have seen it lasting, even biopsy proven ATN. I have seen it in a transplantation recently, lasting on biopsy 3 months post-transplant. We did 2 or 3 biopsies in this patient, and he has ATN, ATN, ATN. We saw the slides ourselves with the pathologist. Just ATN, 3 months, dialysis for 3 months, and then boom, complete recovery. Certain factors predictive of mortality, male gender, I don't know why, oliguria, mechanical ventilation. If these patients, if these things are happening, the prognosis is the probability of mortality is high. The key steps in the management: avoid nephrotoxin, avoid further damage. Very important. Review the medication chart. You know, other doctors order things, NSAID, antibiotic, contrast. Let the patient heal. I really am a strong believer in God creation and the power of human body to heal. I showed you that autoregulation mechanism. There's nothing like it. So human heal, diseases heal. That's a rule. Diseases, all diseases actually heal. We have to, if they're healing, just try not to cause problem during the healing process. Prevent and treat infection, provide adequate calorie intake, extremely important. Calorie intake is very important during the period of AKI. Okay, so at least just on the surface of it, you're preventing the protein breakdown. So that's why you provide calorie intake. So protein doesn't break down and burden the kidney with more creatinine, more BUN and stuff like that. Protein, water, sodium, potassium intake should match losses. Monitor the vitals, the weight, the blood chemistry, and dialytic therapy. We do dialysis immediately if it's indicated or needed. Hyperkalemia is a serious problem. I call it the killer K. In my experience, I don't know where I got these numbers from, but if the potassium is 5 to 6, the first thing you see is a tall peak T waves, very tall T waves, taller than your R. Then if the potassium is going up further, 6 to 7, you see the flattened or absent P waves. And then if the potassium is getting still higher, you start 7 to 8, you start to see the widening QRS complexes. Very ominous sign. You don't want to see that, please. So, and then at this point, you're going to see the sine waves, which I'm going to show in the next slide. This is when the potassium is really skyrocketing, very scary sine waves. And following that, you're dealing with ventricular fibrillation, cardiac arrest. So hopefully you wouldn't reach that stage. From the stage of tall peak T wave, do something, treat the hyperkalemia, different method. This is the sine wave I'm talking about. After this, you see ventricular fibrillation, arrest, cardiac arrest immediately. Methods of treatment, the calcium we give, and the calcium is basically stabilize the myocardium. It buys you time. It gives you 30 minutes to do something. Just 30 minutes. When you give the 10 ml of 10% sodium chloride or sodium gluconate IV, you basically just stabilizing the myocardium so it doesn't degenerate into ventricular fibrillation, cardiac arrest. The glucose and regular insulin IV, the 50 ml of D50, it helps you, it gives you 1 to 4 hours. Do something. You got 1 to 4 hours. The patient is, so you have to think what you're going to do in these 1 to 4 hours for this. This is just a redistribution issue. And by the way, the glucose here, in the past, we used to think that we give because insulin drive the glucose intracellular and it drag the potassium in it. Wrong. Insulin itself, independent of the glucose, insulin itself actually drives potassium intracellular. Sodium bicarbonate, yeah, sure. It's very simple to understand. Give sodium bicarbonate. When you give sodium bicarbonate, that will drive the potassium intracellularly also. Okay. So, and then albuterol nebulizer, sure. It doesn't cost much. It's nebulized albuterol, beta agonist. Again, it gives you 1 to 4 hours. Sodium polystyrene or whatever Kxalate, these resins, they work for days. If you can get a good bowel movement, give 30 to 60 grams orally or rectally, and it buy you time. It buy you a few days of time. If you have 2 or 3 bowel movement, you have to have bowel movement. If you don't have bowel movement, it's not working. So if you don't get bowel movement, give them some laxative of some sort, move their bowels. Okay. And there is always dialysis, of course, available for you. Indications: refractory volume overload, electrolytes, serious electrolytes, especially hyperkalemia, uremia, pericarditis, of course, a severe acidosis, hypercatabolic state, and if you need to remove any toxins. Animal studies have show less morphological and functional damage in non-oliguric ATN. We always like to differentiate ATN to oliguric and non-oliguric. Very, very important to know that in the management. Similar data in human. Loop diuretics, mannitol, beneficial in early ATN, but not after 3 to 4 days of oliguria, where there is no shortening of duration of renal failure or dialysis required. I think I'm done. If there are any questions or comments, please go ahead.